All right, we're going to change gears here. We're going to talk about anorectal disorders.
Okay, so let's talk about foreign bodies. So when can we remove a foreign rectal body? So if you do an exam and if it's palpable, so if you think it's gettable, that's potentially it. If it's less than 10 centimeters from the anal verge, so again, if you can feel it and you think you can safely remove it, it's certainly worth a shot. Absolute contraindications, so if there's any concern for perforation, if a patient has peritonitis, you want to avoid attempting that in the ED. And then relative contraindications, so if a patient's having severe abdominal pain, also if it's broken glass or fragile object like a light bulb. So you don't want to take a chance of further injuring the patient or injuring yourself. So in those situations, get your surgeon involved and let them do it in the OR.
What about legal considerations? So do not attempt to rectally search a prisoner for suspected drugs unless you have the patient's permission. Physicians are not agents of the state. They can't be compelled to act as agents of the state to find evidence. That's the job of law enforcement. A court order cannot mandate you to do this. Your duty is to respect the patient's rights and to go to jail instead. And any patient suspected of hiding drugs, that is so-called body stuffing or body packing, in the GI tract, they need to be explicitly warned of the risks, including death, of not finding and removing those drugs.
Okay, what about hemorrhoids? So for non-complicated hemorrhoids, right, so these are non-surgical, so you're just going to offer them, there's a little mnemonic wash, so it's warm water, analgesics, stool softeners, and a high-fiber diet. You can also use a topical steroid. Now, if they're complicated hemorrhoids, so these could be larger, incarcerated, you can get strangulated, or intractable pain with them. These may require surgical intervention. And then if you have a thrombosed hemorrhoid that you want to treat in the emergency department, you can do an incision and drainage, but you want to make sure to do an elliptical incision to remove the clot, otherwise they can recur.
Okay, what about post-op rectal or anal bleeding? So any major bleeding during the first 48 hours after surgery is usually due to incomplete hemostasis at the op site. So if this was related to hemorrhoid surgery, you may be able to apply direct pressure, you can inject a local anesthetic with epi, or maybe even do a suture ligature if an appropriate site is found. If it's delayed bleeding, it could be due to infection at the surgical site and breakdown. In any case, you should notify the surgeon while the patient's in the ED so that they can have a look.
So anal fissure, so this is the most common cause of painful rectal bleeding. It's usually midline and posterior. If it's not, you just got to make sure to have other considerations, things like inflammatory bowel disease, cancer can be predisposing, and sexual abuse, right? Always make sure to think about that. So patients can complain of like a sharp cutting pain, and you want to recommend good perianal hygiene. You can recommend the wash regimen we just talked about. Nitroglycerin ointment is also potentially used, and sometimes these patients require surgical intervention or even Botox has been used.